Thank you for coming out so early. Thank you. So thanks very much for coming, and we're very pleased to be here in Paris, being involved with the EACD meeting. We're going to be talking about pain today and how we can look at pain management to promote participation. So I'm going to start, and then Professor Susan Stott is going to come up and talk about musculoskeletal pain as one of our common causes of pain. And then Rachel, realize your name is spelled wrong there, Rachel, sorry about that. Rachel is going to present a stakeholder perspective. And then Ross Drake, who is a pain management specialist, unfortunately is unable to come, but he contributed a case study that we'll still do at the end. So this is what our objectives are. We want to understand the need to clinically inquire and assess for pain in individuals with cerebral palsy, have a working knowledge of clinical tools for identifying pain in this population that can be implemented into your clinical practice, be able to identify potential causes or risk factors associated with pain for the development of a thorough differential diagnosis, and then have working knowledge of a pain management framework so that when a person comes in and you remember to ask about pain, you have an approach to starting to provide some pain management. So I'm going to aim to talk for about 20 minutes. Sue Stott is going to come out and speak about musculoskeletal pain for about 20 minutes. Rachel's going to provide a stakeholder perspective. And then we're going to engage in some open discussion and also review the case. So interestingly, over the last 10 years, I think we've really become aware that pain is a big issue in cerebral palsy. And there's some important background for why it is such an important issue. So aside from it being frequently missed by clinicians, individuals with CP and pain are less likely to participate in life situations and have a lower quality of life. And then Culver in the Sparkle study identified that pain in CP is the most important factor negatively impacting on self-perceived quality of life. Pain is very common, and increasingly we're becoming aware of this in cerebral palsy. So this is a study that we published in Pediatrics, and we consecutively recruited children from our clinical practice and then did a pain screening. And we had a physician assess the pain as well and give a potential etiology to the pain. So this particular slide shows that in our study, we had a quarter of children that were in moderate to severe pain. So that's represented by the green, yellow, and purple. And this was based on the HOI-3 pain question. And the reason that that's important is it really grounded the pain question in terms of restriction on their activities of daily living. So really trying to embed it in the ICF framework. So we had a quarter of our children that were restricting activities. And then in the purple, that was 5, where there was close to 4% that were in severe pain that prevents most activities. We know many other features of pain. So one of the common things that we're aware of is that as the severity of the physical disability increases, the percent of participants that responded that were in pain increased. Sorry, this one's a little bit out of focus, but as I mentioned, we paired the pain assessment with a physician diagnosis, and what we found was musculoskeletal deformity was common, and hypertonia were the common reasons for pain in this particular subgroup. We had other causes, so post-surgical pain. And then we also had 27% where the subject was reporting pain, but the physician did not diagnose pain. There's limited information on change in pain over time, and this is a body of evidence that I think we really do need to enhance. What we did was a follow-up study to our initial study that I showed you, where we looked at the prevalence of pain, and were able to recruit children between 6 months to 4 years after that initial assessment. And we asked them whether the pain question again. And so one of the things we found was that pain did change in relationship to the GMFCS level. So it was easier to improve your pain status if you were functioning at a GMFCS level of 1, and you had more chance of having chronic pain if you were functioning at a GMFCS level of 5. And then this is the data that we summarized in terms of the change in pain. So 45% of children had no change in pain, and within that, about half of them had chronic persisting pain, and the other half had no pain. And then you can see that our graph is skewed to the right, that there were more children developing pain. So in this particular data set, we had an increase in pain over time. It's one of the few studies that has looked at that change in pain over time, but there's a beautiful study that came out of the Netherlands, published in Developmental Medicine and Child Neurology, that used a population-based registry, the CPUP, and also identified a high proportion of children who had chronic persisting pain. The other thing I want to highlight for you is that there's some really interesting data coming out of our translational research and our colleagues that are doing translational research. And this is an excellent review article in Nature Medicine on neuroplasticity as a maladaptive response being a key element of leading to persistent chronic pain. And there's increasing understanding of the many mechanisms that this occurs in. So this is just some examples of how the nervous system can be primed to perceive pain. The other thing that happens as well in the nervous system is that there's a decreased inhibition centrally coming from the brain to dampen the pain. So it's a combination of increased excitation, of sensing the pain, and then a decrease of the inhibition of the brain, so to suppressing that can lead to persistent chronic pain. And certainly some of these neuroplastic elements are contributing to the story of pain in cerebral palsy. So this is just one example. If you look at the connectivity in the middle, you can see that there's hypertrophy and sprouting, so that increased opportunity to sense and perceive pain. So there's a clear need for translational neuroscience that explores these concepts and models relevant to CP. And when we look at musculoskeletal and hypertonia pain as the two commonest sources of chronic pain in CP, looking at this translational research, you can see that they could generate a neuroplastic response that can perpetuate and lead to a hyperalgesic state. So let's move now to a framework for managing pain in children or individuals with cerebral palsy. And we've nicknamed this the ADOPT framework. So the A stands for assessment, D, demystification of chronic pain, O, optimizing health management. P is promotion, both of physical wellness as well as psychosocial wellness. And then T is treating pain. So we'll talk about each of these, or I'll talk about each of these. So let's start with the assessment. So assessment is really key, and we already know that pain is very common in individuals with cerebral palsy. So various studies report between 30 to 70% of individuals are reporting pain. But when we look at our clinical reports, health professionals are frequently missing this presence of pain, and so missing the opportunity to actually manage it. So what this means is that in every child, we need to figure out how we're going to systematically ask a question about pain in our assessment. And then the other side of things that puts more onus on the individual and caregiver is that there can be some strategies that could encourage the caregivers to bring up the pain question in a clinical visit. So assessment in the ICF framework is really important. We've been hearing a lot about the ICF and how it can really help to guide practice. And when we're looking at trying to assess pain, we really need to look at several different elements because they'll give us clues in terms of how we can start to manage it. So we certainly need to assess health issues and within the body structure and function, because one of the strategies is really to optimize health in those areas. But we also want to assess the impact of having pain on activities and participation. We've already heard that there's good research showing that as you have chronic pain, you restrict your daily activities and participation in meaningful events. And at a psychological level, that helps to negatively reinforce the pain and lead to a negative cycle. You also should assess the fitness activity level and assess the psychosocial well-being of both the individual and caregivers. So we had talked a little bit earlier about some of the neurology around pain sensation. But one of the things that you may remember is that in addition to the sensory processing, you have feedback into an emotional response, a negative emotional response to pain. And so quite frequently when you're in chronic pain, you have feelings of sadness and depression. So it's always hard to change practice, and one of the things that can be helpful is if you can pull together a toolbox so that clinicians can access it to look at ways that they can measure pain. So Shauna Kingsnorth, who runs our evidence to care unit at Hull and Bloorview, did pull together this toolbox for measuring pain for children with disabilities. And it's really from a clinician perspective. So you can access this toolbox at this website. There's also a publication in PEDIATRICS. And it just goes through commonly available assessment tools for clinicians so that they can look at what might work in their practice. Frequently, people use the body diagram, and that's something that you can give people in the waiting room, and they can circle if they're in pain. I sometimes smile at this because I'm married to a spinal surgeon, and he does this pain diagram as well, and he knows that he's in trouble when the whole body is circled. But it gives you an opportunity to open up and start to talk about whether the child is in pain, and it's fairly quick to do, which is important in clinical practice. The FACES pain scale, that's the revised version here, is also something that's fairly easy to integrate in practice. So I just presented here. And again, you can give it to the individual with cerebral palsy and ask them to reflect on if they're in pain over the last 2 weeks and have them circle a face. And it's a good opener to start to talk about pain. We utilize it in some of our clinics when we know that there's chronic pain problems. So one of the clinics I do is a hypertonia clinic, and I have children with pretty significant dystonia. And how I find this particular one useful is to give it to the parents as well as the child to see if there's any differences in perspectives between the caregivers and the child, and there often are. And again, that's just an opportunity to open up the discussion. Demystification of chronic pain is also really important. Families often aren't aware that their child is in pain. I had one parent who said that they didn't really understand that the young child, when they were crying or irritable, was in pain until that child got older and they were able to start to open up the pain conversation. So it's really important to take the time as a clinician to explain the causes for pain that you've diagnosed. And many times there's multiple causes. And then you can provide the context for pain and cerebral palsy, so you can talk about how frequently it is present. And then you can start to input some of the suggestions around management. So you can start to talk about the importance of breaking the cycle of chronic pain by moving on with activities. And we're going to talk about that a little bit later in the framework. But one of the things that you want to try to get that individual doing if they are in chronic pain is to start to re-engage with activities that are meaningful for them. And it helps to break that negative focus on being at home, always focusing on your pain. So optimizing health management, including a prevention focus, is really important. If you are fortunate enough in your clinical practice to have a continuity of care model where you follow individuals with cerebral palsy over time, it really helps to empower a focus on prevention. And it really is one of the cornerstones to managing pain in individuals with cerebral palsy. Unfortunately, the differential diagnosis of pain in children with cerebral palsy is really vast. And I mentioned already, hypertonia and musculoskeletal are the common causes, but there are many different causes, including our treatments. So AFOs is a frequent cause of mild irritating pain for some of our individuals. And then just in terms of commonly missed or underdiagnosed causes of pain in CP, I've got dystonia here on the top, and I think that it's changing. I think as clinicians, we're much more aware that dystonia can cause pain, particularly if the individuals are getting stuck in postures. GI tract is always one of my suspects for causing pain. I'm going to assume that every single person I see has constipation, and I'm managing that on a regular basis. Posterior drooling, choking on saliva is a hidden cause, and it can lead to night awakenings. GE reflux is also important. And musculoskeletal, we'll hear from Sue. Dystonia, for those of you who aren't familiar, at the American Academy, we've started to develop care pathways, and we do have a dystonia care pathway on the American Academy site. So if you are managing dystonia in individuals with cerebral palsy and you would like to have some guidance, please feel free to visit that particular site. You'll see that gabapentin is in our dystonia care pathway. Constipation, PEG is very good. Promoting physical wellness and psychosocial wellness. So these are key things to do. So we want to promote maintenance of flexibility. We want to promote cardiovascular fitness. There's lots of evidence that if you bring your heart rate up on a regular basis, you feel better. This is important. And participate in physical activities. And then participation and engagement is really key to managing pain that's chronic, and also support and relief for primary caregivers. So just finishing off with treating pain before I hand over to Sue. So pain medications we have to be really careful around. We don't want to use opioids on a chronic basis. They do, of course, have a role to play post-surgically. If you're in a chronic pain setting, gabapentin can be helpful. It can suppress some of that maladaptive neuroplasticity of that extra excitation. And then tricyclic antidepressants also can have a potential role because that can target that decreased inhibition coming from the brain. And then we have strategies looking at cognitive behavioral therapy approaches. We don't have evidence right now in individuals with cerebral palsy, but we certainly have evidence in other chronic pain conditions. So I'm going to turn over to Sue now, and we're going to hear more about musculoskeletal causes of pain. Thank you.